Welcome to Who Cares, the podcast that embarks on a profound journey into the heart of empathy and indifference in our modern era. Each episode of Who Cares brings you insightful conversations with a diverse array of guests from various industries and walks of life. But Who Cares goes beyond individual stories. We dive into the larger societal and psychological undercurrents that have led to a perceived decline in collective empathy. Who Cares isn't just a podcast. It's a powerful call to action for reigniting the spirit of empathy within each of us. Let's find the answer to who cares together. Welcome to Who Cares. Okay, so today I have Dede Kennedy, fondly known as Dede, a good friend of mine. I think I can call a good friend now. It's been quite a number of years. We've gotten to know each other, and she is our employee specialist. Getting employee benefits for our group, and you have quite a resume here as I was reading through. You're the president-elect of CAHIP for Los Angeles, a serving member of NABIP Legislative Council, California's CAHIP Mental Health Task Force, on the NABIP Education Foundation Board, chair of the NABIP Legislative Council, Mental Health Working Group, and basically they have a real fondness for mental health in general.
Beyond a shadow of a doubt.
Yeah. So, it's as I read all these, they all sound so serious, but I'd really like to know where your heart is.
I think my heart has always been in helping people, in creating good relationships and building other people up. I definitely try to lead with my heart and my mind at the same time. And I think that's one of the strengths that I have.
Where do you think that developed out of?
It's kind of hard to pinpoint. I think it was kind of always innately there, but I've always been a gregarious kind of a person. And I remember at different stages of my life not being comfortable. And over time, getting to the place where that coalesced into, this is me, I'm really okay being me. And it's okay to be vulnerable and to show and to have my heart on my sleeve.
Do you think that kind of lent to you being able to be more caring and understanding of other people as you got to know yourself better?
Absolutely. And I don't know that it's an outward expression until we're comfortable enough on the inside to let that be what we lead with. I grew up in the 60s and 70s and started in the insurance industry in the 80s. And it was very much a man's world. It was very much if you're going to compete there, you need to be twice as good and look the part. And so it was very structured and had to be always on. So I think that was a point at which it was more difficult for me. I guess the older I got and the more comfortable I got within my profession, the more I was able to let down the guard and say, this is me within that. And I'm smart and capable at the same time that I am loving and encouraging and want to do everything I can to make the world around me better.
So you started out in the general healthcare industry, but it seems like you kind of gravitated towards mental health.
I started in the health insurance industry originally with my dad. He was a pioneer of self-funding. So back in the 60s and 70s, he and a crew were the first to structure health insurance plans on a self-funded basis. And so that's the environment that I started in the industry. And then 7 years later, I left that firm after a couple of different mergers with major insurance companies and became director of contracting for a psychiatric hospital. So I moved from the insurance world directly into the provider side, doing the networking and contracting and negotiations with insurance companies and employee assistance programs, and had an opportunity to set up a independent physician association, an IPA, a behavioral health IPA, in the, I guess that was 1993, 94. And at that time, I think it was one of the first in the state. The facility, the hospital I was working with, did go into bankruptcy, and I was laid off, and I took a position with a women's alcohol and drug treatment facility, doing outreach and marketing with them. In both of those instances, I did also work with the team to make sure that they were really comfortable with the term medical necessity and what kinds of questions to make sure were in the assessments and what kind of charting to have, so that when they then turned for authorization to the insurance companies, that they had enough information to verify that the employee was, or the individual was, definitely needing that level of care. When I left the women's treatment facility, I went to Asia for 5 months. And had a backpack on my back and more time than money, and wandered all the way from Bangkok down to Brunei and down to Bali, and got to Bali and stayed for about a month and a half, and then came back and started an insurance agency. My CPA, I was at my CPA's office doing my taxes, and he handed me his insurance bill. He said, "You've got a license. My rates just went up. Get me a better plan." So that was literally the start of my being an insurance broker and being an insurance agent. And the rest has been 30 years of building on that footing. Couple of the different things about me and my family is that we have a history of depression and mental illness within the family on both sides, my husband as well as mine. And when we had kids, we really thought that, if we just love them enough, if we just give them all the advantages and the resources, and give them a voice and a structure that is supportive, that everything would be good, and that the family genetics would not necessarily play out. And that was definitely not the case with our kids. We both of my children have had suicide attempts. Both have had inpatient stays and a lot of other levels of care as well. And so I think the background professionally, and then the lived experience with guiding children through access to care and being an insurance professional and understanding the role that utilization review plays really led me to a place where I knew that things were not working well. Because if it was trouble for me to access care through my health insurance, paid for by my health insurance, for kids that were bona fide medically necessary, we were seeking medically necessary services. If we were having trouble, then the average American was having an extreme amount of trouble.
Absolutely. So that's interesting, because as I hear you talk, I keep thinking the word advocacy keeps coming out. It's like your word, and it started from a long time ago. Yeah. I mean, does that resonate for you in the sense that you seem to be following that path in many different ways?
I'm being shaped and formed and, and presented at this crossroads for sure. It definitely feels like a calling and like I've been prepped for being at this intersection. I have always felt as though there are those that don't have the ability to advocate on their own behalf and need a voice and need those that have specific skill sets to lean into that space. Part of what I didn't mention is that in my early years as an insurance broker, I became very involved with our trade association. At the time, it was the Los Angeles Association of Health Underwriters. And I began to go to our lobby days in Sacramento and then up to Washington, D.C. as well. So for the last 24 years, I've gone to both DC and Sacramento to speak out about what it is that my clients are experiencing, how the laws are applicable in real life, and then to be able to advocate for good change legislation. And so then here I come to the juncture of having a skill set as a citizen lobbyist, and then having a passion area of being mama bear and advocate in the behavioral health. Now I'm at a crossroad where those two things are merging.
Wow.
And years ago, I heard a senator from Illinois speak out about, at one of our conferences in DC, about mental health, and I'm in the audience with tears running down my face because she's speaking about the realities that I was walking through.
Wow.
And 2 days later, I'm up at a microphone in front of our assembly, 500 people in the room, saying, why do we not have a working group on mental health?
Oh, my goodness.
And they looked at each other and they said, we agree with you, and would you consider chairing it?
Wow.
So I have had the honor and the privilege and joy to be able to lead that at our national level for the last 4.5 years. And then last year we started the same here in California. I leaned into the state saying, we are the test, California's the test kitchen for a lot of experimental legislation and fixed legislation. So it made sense for us to also have a group of specialists willing to step up in that area here in California. So it's been a lot of learning, a lot of listening, a lot of trial and error, trying to create something that didn't exist before. But I'm seeing lots of momentum and lots of wind coming up and buoying up what we're doing. So it's
wonderful.
good stuff.
Yeah, yeah. So, on this podcast, we talk a lot about what facilitates care and what brings on care for people. And I heard you say listening. And I wondered if that for you was a huge element in the advocacy adventure that you're in, and with your colleagues. Do you feel like you're being heard? Do you feel like people are listening when it comes to mental health?
I think the short answer is no, not quite yet.
Okay.
I think there's more momentum, more movement that direction, but I do still feel as though there is unintended bias and stigma, and still kind of pushing against conflicting priorities. And that's something I've definitely experienced within our association, is making sure that we are seen and heard among all of our myriad of priorities. So it's been a lot more getting noisy, getting vocal, getting jumping up and down with my hand up. So it has it's been well received. But there's always a balance when you're talking within an organization. And certainly on the legislative side, I'm super grateful to see where we are legislatively, both in the state, but also nationally, that, right now in March of 2024, we have really only two things that are viable politically to get through the legislative process. One is budget-related items and funding, everything that we do, and the other is mental health.
Wow.
And I'm super excited to see mental health at that level of focus.
Yeah.
Both the House and the Senate have mental health caucus, have a mental health caucus at this time. The Senate just introduced theirs this past October in 23. Wow. And so the Senate is finally leaning in, and California Senator Alex Padilla is one of the co-founders. The other is co-founder Senator Tina Smith, and I had an opportunity to meet her last month in Washington.
Oh, wow. Wow. Yeah, that must have been amazing.
It was great.
Yeah.
And she addressed our group, was talking about different policy areas, and I was really grateful to see the amount of alignment that we had. I had an opportunity to meet with her staffer, and the first thing that they wanted to know is, what do we do as insurance professionals, what do we do in relation to advocacy? And so I was able to explain a situation with a client up in rural South Dakota whose husband needed inpatient care, and the nearest facility was 5 hours away.
Oh, my goodness.
And so they got him admitted, and he was discharged from detox, being told that he no longer met medical necessity, but there was no next step. There wasn't a then bed waiting for him at residential or in a partial hospitalization program. There was no continuity of care, no aftercare kind of program set up, at least as he relays it. And so that's one of the things that when they turned to me, I said, well, your plan clearly covers all levels of care. We need to make that, start making those phone calls, arrange those assessments so that he can be admitted at the next level of care. But because he was discharged, he stopped on his drive back to northern South Dakota. He stopped at a liquor store, got drunk on his way home, and his heroin dealer was over the back fence. So he was in a full-on relapse before he even got home. And a lot of that had to do with the fact that there was no care coordination that materially, physically got him from one level of care to the next. And 2 years later, I'm getting the call again, this time preemptively. I'm super excited.
Terrific.
So at that point, I could coach the wife. It's like, all right, we're starting sourcing the next bed right now. And so the day he was admitted, I was in contact with both of them, and then we were able to get the list of providers and have that set of phone calls start to begin. And he now is little over a year sober and has his credential to be a drug and alcohol counselor.
Oh my goodness.
Yeah,
How exciting is that?
Yeah, it's the
wow.
It's the poster of treatment works.
Yes.
And it, however, needs to not have gaps. And that care coordination, I think, is one of the big things that we're really starting to talk at the national level as missing within the overall delivery of behavioral health care.
Where do you think the drop happens in the coordination of care? Where does it stop? Is it just the inability to communicate or to have programs that are interconnected somehow? Or
I really appreciate greatly the interconnected programs, because if there is a good fit, then there's a kind of built-in continuity from one level to the next, and the assessment team and the utilization review team has all of the chart, has all of the data, is able to make those connections when they reach out for prior authorization with the carrier or the payer. And it's when we don't have the connected pieces, and the patient is typically not in a position to advocate on their own behalf. Really, at that point, there's some form of a caregiver, a family member, a friend, or somebody that's been appointed who is doing that advocacy for them. It's not something that the insurance companies have a staffing level to do. The payers don't, nor does treatment facilities. And so I think where that component fits and who's going to be funding it and who's going to be staffing it is a part of what we need to work out. But it will enable Americans to get care without those critical gaps. And I think that's a big piece in my mind. Workforce shortage is the big one. That is by a long shot, underlying problem that feeds into so many different areas. We're seeing so many problems in not having enough treatment facilities. There's treatment deserts, even in urban areas. And then it's exacerbated when you start to get into rural. We then, of course, have the rate of retirement of our psychiatrists and our clinicians, and there just aren't enough new clinicians that are coming into the space, especially with our much greater need and demand. Our supply and demand is very off balance at this point.
How do you make sense of that? I mean, I noticed a lot of that, people not really wanting to work right now and like disconnected. I attribute it to not caring, and maybe that's, too simple to say, but it just feels that way. It feels like people aren't interested in that as much anymore. And I'm wondering what you attribute that to.
I wish I had a real straight answer to it, other than it brings to mind a conversation I had with my daughter, who is incredibly intuitive and empathetic. And she would make a phenomenal clinician. She really would. And for a number of years, her comment was, it's too much schooling. And I think the time and expense is a deterrent for her. And I know that many of the initiatives that are being developed around the country are trying to address those two things. Trying to create license types that are only requiring a 4-year degree. The Balmer Institute up at University of Oregon is working on that.
Oh, wow.
Specifically training clinicians to go into the school settings. Okay. And the university's collaborated with the public schools in the state to prepare clinicians that are specifically designed for school needs. And I know that there are a lot of debt relief and different kinds of scholarships, that programs that are being out there, many of which are being designed to put people into workforce shortage regions, in addition to working with underserved communities. There's a bill from Troy Carter out of Louisiana. His bill would specifically reach out to put money into outreach to HBCUs, historically Black colleges and universities, and promote mental health as a career path, because the workforce is so underserved for our people of color in the country. So again, specifically reaching out to HBCUs, and then providing up to $250,000 of debt relief if the individual, once they graduate and start seeing patients, are accepting Medi-Cal, Medicare, Medicaid. So putting them where the specific workforce is needed.
Yeah. Wonderful.
So interesting initiatives. Not quite off the ground yet, though.
No. Well, what do you think is impeding that?
Cost. The limited scope of, if you put $100 million there, how many clinicians actually get over the finish line, and does that then put into the workforce? And I think that we just need to commit to finding those ways and working with scholarships, working with some sort of student debt relief will really help, because particularly when you've got a student coming out of their master's program or their bachelor's program in some locations, usually masters, in those scenarios, typically the individual will be working on their hours and doing that in a supervised environment, and those their rates of pay don't necessarily provide a living wage in addition to also at the same time paying down your student debt. And so that's the economic reality, I think, that needs to be addressed. And if we have a high priority on a really abundant, well-trained workforce in behavioral health, we must find ways to overcome the financial barriers, the time barriers, the lack of access or awareness of behavioral health as a career path.
So you have 2 kids in this generation. What do you think they care about? What do you think their biggest cares are that may be different than our generation?
Well, I know that both of them have a level of self-awareness and self-disclosure and willingness to be open
So
and
more vulnerable.
much more vulnerable and authentically who they are.
Yeah.
That is a product, certainly in part because both of them have been in behavioral health treatment and have been taught and coached on that. Both are very emotionally literate, and that I think is a key thing. But I do see that across their friends and across the generation. I think there's less stigma. And more ability to embrace the "it's okay to not be okay" phrase and kind of slogan. So I just think that's hope for the future.
Yeah. So you feel like they're more caring and accepting of their friends and their, peers.
Absolutely. We are still human. We still do have stratification. We still do have cliques and all of that. But I think at the same time, we have a narrative, and certainly the pandemic brought this home a lot stronger and a lot more in their face, in their real world, was that everybody's struggling and that it's okay to struggle.
Right.
And then what do you do with that? And what I love is the willingness to be asking the question of what can I do? And well, let's go out for a walk. Let's go do this, just to again be more proactive and not just on the sidelines.
So you brought up the pandemic. Maybe with the pandemic, I'm thinking that the priorities got refocused because it forces you to kind of think about what's important, right? And, to figure out what we really care about and what's right here, because it's affecting all of us.
Absolutely.
Yeah.
I would love to see the studies and the research that's going on related to all of the ways that the universal trauma, the way that that's going to manifest in people. It's one of the things that when I'm talking to different people in different groups, it's okay, guys, we're going to have 10 years of trauma. So it's going to take 10 years for that to bubble up into acting out or having difficulties of some form. And so this is a long range and long-term recovery that we've got to focus on. And we need to be prepared from a both human perspective, but then also for those that need care, being able to provide that care. And the area that I sit is the funding of that care.
Right.
And making sure that the funds are available and the cost is not a barrier.
Right. So where do you see that for the future? I mean, that kind of gives us a snapshot of what's going on today for you. But in terms of your future, have you thought about, where that's leading you next?
It's hard to say other than I'm getting drawn into a lot more speaking, a lot more teaching. One of the things that we did at the NABIP Mental Health Working Group in our first year was I thought we were there to lean into legislation. That the mama bear in me was like, okay, let's get this stuff fixed, right? I can absolutely tell you what the problems are. Now let's get that stuff changed. And that was a component of what our work at the time working group was working on. And then we shifted over also at the same time into training and education. We realized that all of us as an industry, all health insurance agents, folks that work within our agencies, we don't have enough information to be truly competent and confident advocates, so that when a client calls us and says, my husband just got discharged, what do I do? Or my daughter's going in, how do I do this? Or this authorization for intensive outpatient has been denied, what do I do? Again, there was a lot of information I had. And so our group spent a number of months putting together curriculum that builds in a lot of the the foundational information that we need about delivery of behavioral health care, about what the laws require plans to cover and where to find that information. And then what does the patient experience look like as they're going from one level of care to the next, and where are the places that we need to make sure that we're coaching the caregivers and the family, or helping to provide that advocacy ourselves. And so that particular course, we've not seen any content like that anywhere in the country. Wow. Certainly for our industry. And it's now starting to pick up steam as something that's being toyed with as being a training session potentially for the legislative aides for the California State Legislature. Oh, wow. And HR departments. Yeah. And a number of other different focuses of the lens of this. What's the experience like? What's needed? What's missing? What do you need to be able to actively and competently be able to help when that call comes? And it's, I think I've got 12 different 1-hour sessions set up for the next 8 months.
So it's a lot of education and training in that area.
Heading to Georgia, heading to Phoenix. It's going to be a lot. And it's for this mama bear heart, right? Yes. If I can just have one more advocate out there, make a difference in one more person's life. Right. And obviously wanting to magnify that. So it is, I don't know if that's a pivot in my career, but it's absolutely something that I am excited about. I still own my health insurance agency. I don't see that as something that I'll change away from, but I love this. This is, again, feel as though I've been molded and formed and given this professional experience, life experience, and then the lobbying experience is like, all right.
Yeah. Yeah. Is that how you feel cared for, is when you can make an advocate, when you can create that in somebody?
Absolutely. When I hear that someone their life or their journey is made better, that I get the heart swell, all the feels, that rush of warmth, that sense of purpose, absolutely comes from knowing that one person was touched. And if, as I look at it, if I can play a part of training the folks that'll be doing that, that's awesome.
That is really awesome. So if you could tell a budding therapist one thing about this whole journey, what would you want them to know?
That they have the chance to change lives. That what therapists and clinicians do is appreciated, is needed, is a calling. And I've been in so many family therapy groups. I've been in, so many multifamily groups, as well as, guiding my kids through their journeys. And our therapists in those settings have made all of the difference. They have saved my kids' lives. They have kept our family communicating in a way that is positive. Again, the healing and the ability for that to transform is, I get stuck there because, I don't want to get uber dramatic, but it can't be understated. It's so important to the individuals and the families. It's it's touching so many different people, not just the patient.
Right. It's got kind of waves through their whole life. Completely. Right? Yeah.
Completely. And for years and decades to come.
Right.
They then are given an opportunity to make a difference in their realms.
Oh, well, I appreciate you being so frank and open about all this and vulnerable. And I mean, it really shows how much you do care and love and support and want things, better for the world and everybody else, and how it comes through motherhood and how it comes through, your career and everything, and what a journey it's been for you.
Absolutely.
Yeah. Yeah. So thank you for that.
I appreciate the opportunity to, celebrate it, to acknowledge that it's born of difficulty and pain, but at the same time, it's making that benefit others. And that's right. I couldn't imagine a better outcome. Other than my children healing and having a chance to be whole and happy people.
Right. So it's like it came through the back door.
Yeah.
It wasn't the way you thought it was going to happen for them, but it did happen, right? I mean, their healing came a different direction than you and your husband had originally foreseen.
Completely. And what I'm super excited about is that they have a skill set that is going to be a strength for their lifetime.
Yeah, so it's even bigger.
So, back to the contribution that the therapist makes, it's, again, that comes from there.
Yeah.
And it then is made real by the individual getting an opportunity to live a fulfilled life.
But not without Mama Bear advocacy.
Exactly. Well,
thank you so much.
You.
Thanks, Ddee. Appreciate it. Means a lot.